This is the first webinar of the webinar series focused on community-defined practices, brought to you by the California Institute for Behavioral Health Solutions Health Equity Team. We would like to thank our sponsors, the Mental Health Services Act and the Department of Health Care Services, for supporting this webinar series. Our webinar today, entitled Key Ingredients of Community-Defined Practices, is intended to set the foundation and give an overview of the Community-Defined Practices Capacity Building Project. We hope from the information shared today you will get a better understanding of the project and determine if the key components are a good fit for your program and continue the process. It is a privilege to have with us today's presenter, Dr. William Rhett Mariscal. Dr. Rhett Mariscal is an Associate Director with the Health Equity Team at the California Institute for Behavioral Health Solutions. As a lead in providing technical assistance in the area of reducing disparities and the primary point person at the agency in the Prevention and Early Intervention component of California's Mental Health Service Act, he was part of a team helping LA County develop and conduct their Community-Defined Evidence Program Identification Process for PEI programs, providing TA to agencies helping them articulate their practice models in a way that would allow LA planning area to select a practice for implementation by local providers. He has also been involved in several practice dissemination and implementation support projects, working with program developers and agencies learning and implementing programs. At this time, it is my pleasure to turn it over to Dr. William Rhett Mariscal.
Thank you, Sharon. I appreciate your introduction, and welcome everyone. I'm pleased to have you here joining us for this webinar and participating in this journey to really support community-defined practices and those practices that have a particular relevance to our communities. So what we're going to be covering here is in the beginning of the presentation, I'm going to be starting off with some background information around community-defined evidence, community-defined practices, terminology, have an understanding of worldviews and how that impacts understanding of healing, and the relationship of culture and healing. So that's going to give us a background. And then we're going to look into the three components that we've identified for the capacity building that we're providing in this project as key ingredients for a CDP, community-defined practice, that are ready to be incorporated and funded by systems like the public mental health system. So just even to begin, these core ingredients, the key ingredients that we're looking at are those things that we think are key ingredients for practices that want to be taken up or funded by systems. They're not necessarily key ingredients of practices that you need to have in your own communities for the existence of these practices, but they're key ingredients for support in the system. Okay, and then when we're done with going over those key ingredients, we want to talk a little more again about about the project and the opportunities that you have in participating in this project and what some next steps are. And again, I'd like to invite you that throughout you can submit your questions and comments. We will have time at the end, not quite the 30 minutes, but sometime at the end, definitely for a more robust discussion. But right now, I'd like to try to go through some of this information for you and share it with you. And if we have opportunity throughout, we might also pause for some questions if they seem relevant too. Okay. So, all right. So, first of all, just a little context. Why focus on community-defined practices or community-defined evidence? We'll get into terminology later, but why focus in this area? Well, first of all, this interest in community-defined practices comes out of a general concern that has been existing in terms of how do you know that services are appropriate for the people they're intended for, and that they are meeting the needs, and that they are effective at meeting the needs of the people the services are targeted for. And this is driven out of a concern about what's called business as usual services, where people provide services without too much evaluation or understanding about whether these services actually meet the needs of the people that they're serving. That the ways they, or that the ways that people understand whether it works or not are maybe, they're not too much analysis has gone into it. So they're not super informed in terms of how that practice works or not. So this is a concern. And an example that is typically used about this concern about business as usual, that's not a cultural example, but it's just a general example, is like the DARE program that was popular in the late 80s or in the 80s in terms of a drug prevention program. And a lot of schools were using them. There was a partnership between schools and law enforcement, and really took it up because they were told it works and people believed it works, and a lot of kids were involved in that program. But once people started actually studying the impacts of that program, they found that it was not making a difference in reducing drug use. So that the program was not effective, even though people promoted it as if it was, but they were promoting it and just doing it, following a kind of a business as usual model of people disseminating practices without actually having a close look. So community-defined practices is part of this concern, comes out of this concern for having a better understanding of what works and what doesn't work. But in particular, it is focused on this issue of that there are standardized practices, universal practices that might not fit communities from different cultural and linguistic backgrounds. So it's in part a response to what are called evidence-based practices, practices that are researched and are using research methodology that tries to validate the universality of a practice, and then questioning whether these practices truly do have universal application, or if there are some concerns about language, cultural norms and values, and other areas where a practice might not fit a certain community. So therefore, in response to a practice that's developed kind of more universally to apply to multiple communities, this idea of a community-defined practice is a practice that comes from a community itself. So it kind of comes out of that environment. And then lastly, there's also some concern that communities have about the imposition of practices on them that have been considered to work outside of the community. There are people outside of the community that says this works, and therefore this is what we're making available, this is what we're funding, this is what we're supporting, and this is the service that's available to you. When the community might say, well, gee, that practice doesn't really fit our values, and it doesn't fit our way of doing things. And we have practices, we have healers, we have people that we think that really do meet our ways of healing. And you are not supporting those practices, you're just imposing these other practices on it. So all of those are some of the key contexts in which the focus on CDPs has been growing and growing over the years, ever since the term community-defined evidence was made public in 2007 from the National Network to Eliminate Disparities. Okay, so but let's go back and start with that original term, the community-defined evidence term, in that definition. Here I'm citing a definition from 2010, but it's identical to the definition that was first coined in 2007, but this is out of a published article, so that's why I used it out of this 2010 definition. But let's look at this term, community-defined evidence, and then later we'll look at how it relates to community-defined practices and other similar terms. And this term is that it's community-defined evidence is a set of practices that communities have used and determined to yield positive results as determined by community consensus over time, and which may or may not have been measured empirically, but have reached a level of acceptance by the community. Now, one of the key things I'd like to focus on in this definition is that it's this concept of community, and there's also this concept of community consensus, and then Also, there's this idea that a community determines and accepts. So I'm going to break these words down a little further so you can see what is implied by this definition and how that is informing the work that we are offering, the support that we're offering in this project. So you look at the key terms in the definition, you look at community, and then I just looked these up in online dictionaries and consolidated some of the words, but these are some general definitions of these terms. So community is a group with a common historical or cultural heritage, sharing common characteristics or interests, and perceived or perceiving itself as distinct. So I think this is important. In this language of community-defined evidence, community-defined practices, I think it's really critical when we start getting deeper into it to understand what is meant by community. So here's the definition of community. Then there's this element in that definition. If you look at it, says that if you go back and you look at it, and it says determined, the communities have used and determined to yield positive results. So what does it mean that a community determines something? Well, the definition of determine is to find out by getting information and to decide based on evidence. So when this definition that Ken Martinez and others developed says that it's practices that communities have used and determined, it means that the community in some way has found out, has gotten information and has decided based on some kind of information that the practices works. Then the other key term in the definition is consensus. Consensus is like a general agreement or a majority opinion that the majority of people, so in this case of a community, the majority of people in the community would agree that the practice works. And it says, well, it works by this definition is yield positive results, so that the practice yields positive results. There's a consensus. And then lastly, there's this term of acceptance, and have reached a level of acceptance by the community, which is key in the definition. So what is acceptance? That means that there's approval, there's belief that it works, there's people that support it and say, yes, this practice works. So these are key terms, and I think as people have been moving forward, we've not always focused on what this definition of community-defined evidence is and what these key components are. So let me paraphrase that, if it's helpful. So we think of what is community-defined evidence. Using the Ken Martinez's definition, these are practices used by a group with a common heritage and shared interests and who see themselves as distinct. Okay? So used by a group with a common heritage and shared interests and who see themselves as a distinct group, as a distinct community. And these practices have been found by members of that group to have good results. So they're not just practices that are used by this community, but this community has found them to have good results. They don't just use them, they also see them to have good results based on information they have gathered. And this determination that it has good results is based on some kind of information they have gathered. And they have a common general agreement about those good results. And then if you talk to people in that community, there'd be this general agreement that there are good results from this practice, to the point that the group in general approves of the practice and believes in it. So, and that's pretty interesting when you break that down, when you look at it, and you think in terms of what a service provider agency does. A lot of times it is not. What agency providers do are not necessarily always what is implied by this definition. So that's why I wanted to really spend some time to break this down. Now, I'm not saying that they're not, but I just wanted to emphasize some of these key elements of this definition, this original definition of community-defined evidence, which is also included in the when the state released the guidelines, the draft guidelines for the prevention and early intervention component for the Mental Health Services Act. They issued a resource guide of practices that could be supported in prevention and early intervention, and they talked about 3 different types of practices that could be supported: community-defined evidence practices, evidence-based practices, and promising practices. And this was the same definition that was used at that time in the state of California by the State Department of Mental Health in their resource guide to discuss about what community-defined evidence is. So, okay, so let's go from here and let's go into this a little further. What does this mean? I think it's critical to point out that this means that an agency or agency staff does not equal community. So to say that a practice has been accepted, developed, validated based on the work of one agency and its staff, I don't think that's what this definition is capturing about what community-defined evidence is. I think that the intention of the definition was to talk about an ethnic, cultural, or regional group that is served by an agency, but not wholly, solely contained by the agency. It's not just the agency itself, and only the agency represents a community and is a community. Instead, the agency serves a community. So we're talking about something broader than the agency. But are we talking about the clients that the agency serves? No, I don't think so. I think this definition does not mean that a community is only and solely 100% defined by those people that an agency has actually served, the actual clients that have gone through the agency. I think it's pretty clear when you look at a definition of community, we're talking about something broader than that. So broader than the agency, broader than the clients that have been served by the agency. We're talking about a group of people, including those who have not been served by the agency. So, but does this mean the broad service, the population that an agency draws from, even though they're mixed ethnicities and mixed national origins and are diverse and don't see themselves as a distinct unit? I don't think so. I think if you go back and look at the definition again, a community is not a disconnected population. It's a population that has a distinct identity, that perceives itself as distinct. And then lastly, what does this mean? Does this mean that a community, can we gauge community acceptance by saying our agency serves so many clients from this community per year, therefore the community accepts this practice? I don't think either. I think what's really interesting when you look at this definition is that community acceptance should mean, if you go back at it, that if you ask people in the community about the practice, they would agree that it works. So you don't only rely on how many people you serve as evidence that this practice is accepted by the community because, well, you've had 100 people come through your agency and through this practice, therefore this practice is accepted by the community. I think what this definition implies is that you got to go further and ask the broader community whether or not they would agree that this practice is beneficial and yields good results. So I think that's, when you go back, let's look at it again, a set of practices that communities have used and determined to yield positive results as determined by community consensus over time, and which may or may not have been measured empirically but have reached a level of acceptance by the community. I think you go back and you look at this definition, these points that I have been making here follow from that definition. Okay, so when you try to wrap your head around that, if you're an agency on this webinar and you're thinking about, do I have a community-defined practice or not, and is it possible that I can have a community-defined practice or not? Certainly, I just wanted to have that definition so you could understand the distinction between a community-defined practice and just a program that an agency has. Because agencies develop programs all the time. They create new programs. They're always doing programs and getting funded to do programs. But what is a program that an agency has created, which is our after-school program for kids, and what distinguishes that from a community-defined practice? So that's what we're trying to help with that, going over that definition. And particularly, I want to give some examples here of categories that would be good examples of community-defined practices. So for example, in various communities that consider themselves distinct and independent communities. They believe that rites of passage ceremonies are critical for the development of youth into adults and for their well-being, for their mental, emotional, physical well-being. So rites of passage are accepted by community members. If you ask members of these communities, you said, hey, do you think it's critical for our youth to go through rites of passage, and do you think it's beneficial, and do you think it yields good results? They'd say yes. Now, your agency might have a specific rites of passage program, and they might not know about your specific program, but as long as your program is grounded in the rites of passage ceremonies, traditions, practices of that community, and then we could ask members of the community and say, hey, there's an agency that's doing this rites of passage program that's based on these core principles of this rites of passage in your community. Would that work? And they would say, yes, that should work. I would believe in that. I would send my youth to that program. And the same to say like something like drumming. There are communities that believe that drumming has very important positive results for people who participate in drumming, or dance traditions, faith-based healing. There's values. There are communities that really value talking, having people have the opportunity to come together and talking and support each other in different ways and provide healing and coming together in circles. There's spoken word traditions that really value spoken word as a important process of promoting healing and wellness. There are other traditions that value healers. They could be called shamans, for example, or other types of community healers. And they'd be recognized by community members, yes. A shaman is an important healing practice in our community, and we accept it and we value it and we see it. Or say mentoring, recognizing the value of an adult speaking truth into youth, into their lives, and how critical that is, and to have some kind of apprenticeship or mentoring process. There's some communities that truly believe that that's critical to the fabric of their well-being in their community. So these are examples of what we're talking about then, if you look at that definition of community-defined evidence, of some kinds of practices that would fit. Okay. I promised I was going to talk about terminology a little more, so I just want to, at this stage, talk a little bit more about terms. So, so I gave you the definition that was developed and produced by Kim Martinez and others and disseminated through the National Network of Eliminating Disparities and used in a project that was funded by SAMHSA. And that can be used particularly to talk about the type of evidence, to separate practices that are validated by community-defined evidence from evidence-based practices. And sometimes it's used and conflated and used to talk about the practices themselves. So sometimes they'll hear the term community-defined evidence and people are talking about actual programs, or they're talking about the kinds of evidence that are used to validate the programs. We're using the term community-defined practices to talk about, we're focusing on the practices themselves, but practices that have been validated using community-defined evidence. The State Department of Public Health Office for Health Equity recently released some draft information about their Phase 2 program for their California Reducing Disparities project. And they're using this term community-defined evidence practices, which merges the two terms. It looks at community-defined evidence and then the practices that are defined. So that might be a term you might hear people use, community-defined evidence programs or practices. And we've just shortened it for our project, and we call it community-defined practice. Then, as I mentioned, you hear people talking about community-defined practices in response to evidence-based practices. And so what do they mean by evidence-based practices? Usually people, when they're talking about evidence-based practices, they're talking about practices that have been validated using research methods to determine their effectiveness. But research methods are typically conducted at a university using methodologies like that could go up as high as a randomized controlled trial, and that's considered the gold standard of evidence-based practices. But there are differing levels of evidence-based practices that people will acknowledge in terms of the kind of research methods that are used and and how much confidence there is in that practice being able to deliver the stated outcomes, stated results based on the research methodology that has been used. So there's a range of levels of evidence-based practices that people talk about. And I would say that on some level, to talk about, when people talk about building the evidence for community-defined practices, or when you look at the state California Reducing Disparities Project, at some level, the goals there to hold pilots and build the evidence for them is in part helping practices that have been validated by the community also climb kind of the evidence-based practice ladder and be recognized as evidence-based practice as well. So sometimes these terms can be mixed. And another term that mixes them is promising practices. And that's a term that is often used in the evidence-based practice world to talk about practices that have early evidence of effectiveness, but maybe not enough that they're willing to, that some people are willing to call them evidence-based. Now, all of this terminology is not consistent. There are different organizations that talk about evidence-based practice, and they have different levels of ranking, and they have different definitions of the different levels. But I just wanted to throw some definitions out there for you to help you navigate this world as you are trying to move forward and kind of understanding what the work we're doing in this project is, how it relates to these other terms. Okay, then I thought it would be useful also to talk about some work that has been done at the national level and how it might relate to what we are doing here with this project at the California Institute for Behavioral Health Solutions. So I mentioned that the National Network for Eliminating Disparities, there's a definition that was coined in 2007 of community-defined evidence. California took up that definition in 2009 when it released its draft guidelines for the prevention and early intervention component of the Mental Health Services Act. But also there was funding from SAMHSA to do for a project that was called the Community-Defined Evidence Project. So there's this national project that was conducted that was related to community-defined evidence, and it was focused on the Latino community. And the agency that was funded, the university that was funded, was University of South Florida, and a man named Mario Hernandez, who's heading the project, but who was head of the department that was focusing on this, but the specific project lead was Linda Callejas. So you saw in the earlier definition on the earlier slide, the citation was for Hernandez, Callejas, and Ken Martinez. So Martinez, Hernandez, and Callejas both were involved in this project funded by SAMHSA to identify Latino community-defined evidence practices or community-defined practices. And one of the things they found in this, and part of this project was not only to identify the Latino practices, but also to help move the field forward in understanding what is community-defined evidence and what are community-defined practices. So one of the things they found as they were soliciting nationally for community-defined practices for Latinos is they found that practices fit in all these different categories. There's all these kinds of things that people do to serve the Latino community that are grounded in the community, that come from the Latino community as best ways of serving the Latino community. And when you look at these, you realize that they work in all these different kinds of levels, and they're different kinds of strategies and practices. So they found that there were some practices that are focused on capacity building and consciousness raising, others that are focused on raising public awareness, help people know more about the issues around mental health. There are other strategies and practices that are focused on outreach, reaching out to the community to increase their knowledge about services, and also to help have a better understanding of what services are needed for the community. So there are these programs that are focused on outreach strategies. There are programs and strategies that are used for increasing service accessibility and trying to reduce barriers in access. There are practices that focus on engaging people in innovative ways into the service itself and keep people connected to the service. Engagement is about being connected to the service. Outreach is is reaching out to talk to people about a service, and engagement is that people continue in the service and stay involved. There were practices they found that were really about how to change an organization administratively and in structure to better meet the needs of the local population. They found that there were other practices that were local adaptations of evidence-based practices for Latino populations. So there might be a national evidence-based practice, and they said, well, gee, to make this work for our local population, we need to adapt it in certain ways. And they found that some people were doing those adaptations. And then they found that there were some agencies that were doing interventions, therapies, specifically developed for the Latino Hispanic populations in this case, to address mental illness or substance use issues or violence. Or in this project, they found ones that were trying to address violence in the community as well. So I just wanted to point out that part of the confusion or struggle in understanding and supporting community-defined practices or community-defined evidence is that they can be totally different kinds of practices, totally different strategies, totally different purposes in terms of they're trying to restructure an organization or outreach to a population or just disseminate information. So these things are combined and can be all lumped together, and that's fine because if you do that, then you know, well, if I need to reorganize my organization a certain way, this is some recommendations I have. If I need to outreach to the community, I do it this way. And you'll find that the, for example, population reports that were conducted for the California Reducing Disparities Project, like for example, the Latino one used these same categories that came from Martinez, Callejas, and Hernandez to organize the practices that were collected. Very similar categories were used for the California Reducing Disparities Project. So this is an important thing to understand, that there are practices that address all these different areas. But we want you to know that for this project, for this capacity building opportunity that we're making available to you, we are only going to be focusing on interventions and therapies. That will allow us to be more focused in the types in our presentations, because it's very hard to provide technical assistance and capacity building across so many different ranges of kinds of practices. Very different to be talking about an intervention and a therapy versus a way of reorganizing an agency, the administrative functions of an agency, for example, or an outreach strategy versus a treatment approach. So we wanted to point that out because some of you might find that what you are doing is more of an outreach strategy or an engagement strategy, might be an organizational practice, might be an information dissemination approach, and it might not fit well with this project that we're doing because what we're going to be talking about are interventions and therapies. So we'll explore that with you further after this call, but we just wanted to point that out. And also the rest of this webinar, the rest of our time together, after I'm done with this introduction, is going to be looking at things that are core ingredients of an intervention and a therapy. So they'll make sense if you have an intervention of therapy. They'll make less sense to you if you're thinking about an organizational practice and outreach strategy, an information dissemination strategy. Okay, so you'll see an example of this even today as we talk of what we're talking about. But let's move on. So let's move on here to this one. Another thing I really wanted to just introduce as a background is this idea that there's of worldview and that healing is culturally grounded. So I wanted to talk about that. And I said that this is one of the reasons why community-defined practices are important, because there might not be a good fit between some practices that are designed to be for universal use across all populations with the unique needs of certain populations. So I wanted to talk about that a little further. So what are these unique needs that populations have? Well, one of the things that's really important to inform our understanding of community-defined practices is that there's this concept of a worldview. And the worldview is the perspective from which one sees and interprets the world, and is a set of beliefs about the world and how things are and how things should be. So every community has a worldview. Every individual has a worldview that comes out of their culture, comes out of their community. And that is the way they see the world and interpret the world. Now what does this mean? Let me get more concrete, especially in the area of healing. And I'll give you some more examples later of how this works. But healing is culturally grounded. That means that in an understanding of what is illness and what is wellness differs based on how you perceive the world. And then what healing looks like would then differ too. A very common example from mental health counseling is this idea that in Western culture and Western worldview, becoming an individual and separating from your family is generally conceived as a positive and important step in one's development, to individuate, to separate from the family. And that a family that focuses, that doesn't let their child go off and become an individual, independent individual, that there might be something, some illness in a family situation like that. And that is something that used to be taught, and to a certain extent might still be taught, in family systems theory in Western clinical practices. So this comes from a Western perspective, the importance of the individual being able to step out. And so it's considered an illness if the family is to focus in the family, and there's even a term for that, and that's enmeshed. The family's too enmeshed, that there's no boundary between the child and the parent or the siblings, and it's too enmeshed. Now, what happened is that people started recognizing that came from a limited worldview and did not fit clients that came from other cultural backgrounds and had different views of family and understandings of the role of the individual in the family. That in fact, in some cultures, if that really value connection with family, that if an individual was too separated or disconnected from the family, that was an illness, that was a dysfunction, that something had really gone wrong, that an individual would be separated from their family. And this plays a role in looking at how different communities address family members who are struggling. There are some communities who would never send their family member to get clinical services, and instead would try to bring a community, a family of support around the individual that's in need, rather than sending the individual out to get services. So this idea of worldview and what is illness and what is wellness is very critical in order to provide appropriate services to different individuals who have different worldviews, and is at the heart of what a community-defined practice has, and the argument for community-defined practice, and that's saying, well, we need practices that fit with the values and beliefs of the individual and their family and their community. Okay. Now, lastly, I want to talk, in this introductory section, I want to talk about getting culturally based practices funded. You know, the ideal that people can strive for and should strive for is that you get total support and that money is given to you to do this practice without any questions, without doubting the validity of your claim that this practice works and that it should be funded and merits getting funding. So that would be the ideal. Now, there are other situations, though, where an agency might find or a community might find that they need some kind of translation. They need to do this kind of translation between their practice and the funder and the world of the funder, the system that the practice is being incorporated into. So some components of how to do that, and these are why we're calling these key ingredients for this a webinar and also for this project, is if you're going to translate a project to a funder or to an agency that's going to support your practice, then you might, a lot of times they're going to ask you to articulate your practice model, to tell them what it is that you're doing. They're going to fund you. They're not going to just give you the money without telling them what it is that you're doing. Some people really want you to tell them exactly what it is that they're doing. So you need to articulate the model in some way. They might also want you to present some evidence of effectiveness. They might ask you, why is it that you say this works, and tell us why this works. So there might need to be some translation. You don't get total support, you might need to translate. Then you might get funded to disseminate the practice. And then the other thing is you might find that you may get funded to disseminate the practice and not just do it. So some people get funded to do a practice, but some people might say, hey, yeah, I don't want to fund you to just do it. I want to fund other people to do this practice, so I need you to help train them and disseminate this practice. So then you're going to need a dissemination protocol. You're going to need some plan on how to disseminate this. Okay, so that's all the background. I'm going to get into some detail. Each of these three areas, we're going to get into more detail as we move on with this capacity building project. But this is meant to give you an understanding of these areas that we're focusing on and see, so we can have a conversation with you, see where you need the greatest assistance or might benefit from this project. So practice models. So the idea of a practice model, if you need to talk to a funder about your what it is that you're doing, and they won't give you the money without an explanation, is, well, they might want to know what your theory of change is, and they want to know, so you'll have to explain your theory of change, and they will want you to articulate the components of the model itself. So let me talk about that. So what is a theory of change? A theory of change is this understanding that treatment practices, and this is why I said treatment, we're focusing on treatment practices, should have these following key elements. There should be an understanding or an explanation of what the problem is that will be treated, an understanding of what is needed to address the problem, and then an explanation of why the steps, the actions taken to address the problem do actually lead to wellness. So that's the theory of change. Just like there's a problem here that's going to be treated. This is what we think is what the solution is, and this is why we think these steps that we're going to take are going to bring about that healing. And they're always grounded in a cultural worldview, as we've talked about before. So an example of this is, which could be conceived as a problem or not. So I have here some examples, is a child who's sleeping a lot and not eating. So it could be perceived as a problem from a physical perspective. People might consider, well, there's a physical illness going on. If you have that worldview, you might have a worldview that says, no, this is the result of an emotional illness, or you might have a worldview that addresses this as a spiritual illness, or might consider it an energy imbalance, or it might not be a problem at all. So based on the worldview, you have a certain understanding of the problem. And then in terms of the theory of change, based on that understanding of problem, then there is this understanding of what is needed and how you get there. So I'm going to give you one example. If it is from a physical, or one or two examples. Your theory of change from a physical perspective would say, well, the problem is that the child has a fever or the flu. What is needed, the solution, is their body needs to defeat the virus. How do you get there? Really, the only thing you can do to defeat a virus is get lots of fluids and plenty of rest. So that would be an example of a theory of change from a physical perspective. I'm going to give you an example of a theory of change from an emotional perspective. You say, well, this person is suffering from depression. What is needed? Well, they either need to have a balance, and that depression could be caused by chemical imbalance or might be caused by negative thought patterns. So what is needed? Well, they need to rebalance their brain chemicals. They might need to change their thought patterns, their thought habits, their thinking behaviors, and that's what's needed to solve the problem. How do you get there? Well, if you think it's about a chemical imbalance, you get there through antidepressants, or maybe through exercise that can naturally change your body chemicals. Or if you think it's about a thought patterns, then you'd retrain the thinking through cognitive behavioral therapy. So these are theories of change based on this one, examples of different theories of change based on this child that's sleeping a lot and not eating. Okay. The clear articulation of the practice comes from what needs to be done to actually saying, how do you do it? You specify the who, how, what, and when of doing something. Now, for cultures that value the written tradition over the oral tradition, that would involve creating a manual, usually. And that's a term that's used in practices that's called manualizing the practice. And that comes from written traditions. Oral traditions would not value a manual, but would still value some kind of oral explanation or recipe of who, how, what, and when for doing the practice. So that's what a clear articulation of a practice is, that you might need to do for a funder, is tell them the who, how, what, when of doing the practice. Okay. Now, what are some components that you would be articulating, who, how, what, and when? Well, for example, around the healer you might be have to articulate what are the qualifications of a good healer, what are the skills that they need to use, what kind of training are they needed, how do you recognize whether someone is a healer or not. For the person who is healed, who are those that this practice is for and whose is not for? When can you use this and when not? Maybe if the person has certain things going on, it's not appropriate for you to use this practice, but if they have other things going on, it is appropriate. Maybe it's appropriate for everyone, all ages, or maybe not. Maybe it's only appropriate for a certain gender or a certain age. So articulating these things becomes important. And then what is the treatment itself? What are the actions that are taken? What is the sequence of those actions? Should certain things happen first and other things happen later? And then you typically articulate what is expected to happen and when. Some things might happen immediately during the treatment. Some things might happen shortly after the treatment. Sometimes might happen some weeks or months, and some things might happen only years later after the treatment. So talking about what is expected to happen and when are some key things that you would be articulating of your practice model. And again, we'll get into all of this in more detail as we move on in this project, but just want to continue giving an overview of these. So now I'm going to go over to the evidence of effectiveness. Key things here is understanding how do you know the practice works, and how would you know if it didn't work. So all practices have some way of understanding that the practice works or doesn't, and all communities would have some concern about doing something that doesn't work or doing something that does work. You know, whether someone's a real healer or not a healer. Are they an imposter? Are they a phony or not? Or is the practice real or not? So there's some way of knowing whether something and someone works or doesn't work. So some things to think about. It's like, what's the source of the information that you're using for determining that the community uses to determine whether it works? Is it reports from the clients, that everyone who goes through this, and I'm using the term client, but the person who receives the service? Is it based on what they say, or by observation? Maybe the healer observes a change, or maybe the community, other members, family members, observe a change. So that might be something that you think about in terms of evidence. Data types. Does the data you have, is it numerical, quantitative, or is it non-numerical? Is it stories that you have recorded, or comments that you have recorded, or images that you've recorded in some way? Those would be qualitative. Is the data that you have subjective, like based on someone's opinion, like in their opinion they feel better, or is it supposed to be objective data? Is it considered objective data? That's something that's supposed to be independent of who's the person who's giving the source at all. All of these are things to think about in terms of what kind of evidence the practice has. Other things that people are concerned about when evidence is the validity of the evidence. Is it right, or could there be a mistake? Is there some reason that this data that we're getting, this information that we're getting, that it works? Could it be wrong? Maybe we're collecting the information wrong, or maybe we're collecting the wrong information. Is it reliable? Are the results consistent? Does sometimes you get results that say it works, and sometimes you get results that doesn't work? So maybe you can't really count on it. And all of this should be framed in the context of cultural appropriateness. You know, in errors in how it is collected and errors what is collected, maybe you're collecting the wrong information for the culture of the person or the community that you're collecting the information from. Maybe your method is not culturally appropriate. Maybe doing a written survey is not appropriate for someone who can't read or who doesn't understand English well if the survey is done in English. Or maybe the information that's collected is not appropriate. Maybe it's not valuable to the community member or the community or the individual itself. Maybe it doesn't match their values. Maybe you ask them how individualized someone is to a community that values family. That's not important. And so what's collected is not appropriate. So cultural appropriateness becomes very important. Okay, lastly, I want to talk about practice dissemination in these three key ingredients. And that is, so you have a practice that is accepted, and then you find out that the funders want to fund others to do it. So then suddenly that shifts from someone who's providing the service, whether it's a healer or a community or an agency, to being a service provider, to shifting to becoming a developer, a model developer, and a trainer. And to do that, you often have to have some kind of protocol, some way of training others to do it. Now, a lot of practices, traditional practices, do have a protocol. Maybe it's by apprenticeship. Maybe it's by some other way that this traditional practice was, people were trained to do this practice. But if you're going to train others to do it, you have to think about what's the way of disseminating this practice. So what are some concerns in dissemination? Well, maybe the quality. Is someone qualified to do the practice? Does anyone who want to be a shaman, can they be a shaman? Or do they have to demonstrate certain skill level to do this, so that they're qualified to do the practice? Maybe people are not qualified, they just don't meet the basic requirements for doing it. Or maybe they've learned, they try to learn how to do it, but they just don't do it very well. And so that would be a concern of saying that they actually do the practice. Clarity is another concern people think about in dissemination. How do people know what they're supposed to do and how to do it? How are you communicating that to them? How do they know whether they're doing the practice or not? And then fidelity is another one that's related to clarity and quality, and that's a term that's used that means faithfulness. Faithfulness to the practice is fidelity. But generally people need to know where can they be creative and where not. What are the core elements that you can't change? You can't do this before the other thing. You can never do that. But you can do, this is just an example, but you can do other things. So being really clear of what is fidelity to the practice, what's being faithful to the practice, and what's not is something that a lot of people are concerned about, can be concerned about. So to wrap up here in this overview, what does this mean for this project? It means that we are looking for practices that come from a community, that are bottom-up practices, that are treatment practices, or interventions, maybe intervention in the area of prevention, but interventions and treatment addressing mental health and substance use concerns. We're not talking about top-down academic practices based on universal principles meant to be applied to multiple populations, because we're talking about community-defined and recognized and accepted by the community. And so, you know, and because we're talking about treatment, we're not looking for outreach and engagement strategies. We're not addressing outreach and engagement strategies with these key ingredients. And certainly practices that don't actually address mental health and substance use concerns are not in the scope of this project. So we want to help people articulate, those who are interested in participating in this project, articulate their practice. We want to help those who are interested in receiving this capacity building agencies be able to present their evidence and be able to train others too. Now we know each of you might not have all three of these goals. You might only be focused on the first and the second, or just on the third, or the second and third, and that's okay, because what we're going to be doing is we're going to be working with you to find out what your goals are. But our focus is on those three areas. So we still will need to identify who actually really does fit into the project. And we've got applications from you, but we need follow-up to those applications. Once we determine that you fit, we want to really we'll also be following up to determine fit and to understand your goals, your strengths, and your needs. Participating in 4 more webinars after this that are focused on the 3 areas and on regional trainings. And then also we want people to share their learning with your peers, because we really believe in the value of peer learning. So, do you have a practice that fits this project, and where would you like help would be some of the key next steps to think about. But I certainly want to address questions that have come up.
Thank you, Dr. Rhett Mariscal, for your presentation. Yes, we do have a few questions that have come in, and they were pretty much around the lines of evidence. So one of the questions that came in from Elisa, how would community consensus be expressed for articulating, and what kind of evidence of consensus are we looking for?
Okay, great question. And of course, this is what we would get into more deeply with you. We would talk about what kind of evidence you have of community and what your strengths are around that and what your needs are around that. But in terms of examples of the general concept of what would be evidence of consensus, it might involve doing a focus group with community members or some other methodology that you have of collecting information, of maybe some interviews. Maybe you have a booth at a community fair and you ask people. We can talk about the details of the method, but there are ways of collecting information from members of the community and say, hey, do you think this, does this work? Do you think this works? Is this an accepted? Would you send a family member to this? And different questions we could ask. But I hope that gives an idea of what we're talking about community consensus. Again, community consensus goes beyond the actual clients that have come to your agency or what your staff says. They know it works because they've been doing it and they know it works. It's somehow you got to push out beyond your staff, push out beyond your actual clients, and capture members of the community at large in some way.
Great, thank you. Another question that came in, community citizens recommended strategies to organizations which further developed the programs of which the community has adopted as a viable method to assist their well-being. Would that be community-defined practice? And then also, to follow up with that question, the program in question operated for 18 months, receiving post-program surveys, sign-in sheets, and personal testimony. How much evidence is required?
Okay, again, just a reminder in some of these questions, we're not funding community-defined practices, so the criteria that we're setting up here is not to receive any funding from us or to be accepted from us as in a registry of community-defined practice. So we're not doing it. We're providing capacity building to help you develop your community-defined practice. Okay, so with that in mind, there's still a question of fit. Does your practice fit the capacity building that we're providing? So I think that should be the context for the questions that you're asking in terms of what are we providing capacity building around. So if you have a practice that was developed through community input, then yes, that sounds like that's something that if you asked, again, community members, or you talked to community members and you said, would this work, they would say yes, because this matches what our beliefs are, what works. So I would think, without knowing the details of the program, that a program that is based on community input in terms of what would work would be something that the community would have consensus that it works. It would fit the definition that Ken Martinez and others developed, I would think.
Great. That's it on our questions. Thank you for the clarification, and thank you again, Dr. Rhett Mariscal, for your presentation today. Thank you all for joining us today. Again, next steps is our office will be contacting you to set up an appointment and do an assessment and set capacity goals with you. We also ask that as you exit this webinar today that you will go ahead and please take part in the evaluation. We do read your comments and feedback, and we do use that in our future trainings. And again, thank you for joining us today, and that will conclude our broadcast.